I guess the first step to EKGs is, you know, getting the basic understanding of what it even means when you look at one of the papers, the EKG strips that are printed out. So in the most basic form, and this is the classic drawing that we always see, is your classic representation of your EKG reading. So it starts with being able to identify what a P wave is, what a Q wave is, an R, an S, and a T. So assuming that everyone's already gotten, you know, this, the most fundamental part is that the P wave signifies atrial depolarization. Your Q wave, which is a much deeper topic, but at the most fundamental level, the Q wave is your septal depolarization. And then R and S are ventricular depolarization. And then you go to your T wave, and your T wave is repolarization of the ventricles. So the confusing part, I think, for most people is, if this is what a normal QRS looks like, then how come on your EKG printouts you see all these other representations of it? And that goes into understanding what an EKG actually is. So from the most basic form, you can, you know, first of all, a quick review of anatomy, where we have our atria, and then we have our ventricles, and we have our SA node, and we have our AV node, and then we have our bundle of His and our left and right bundles, and the Purkinje fibers, of course. And there's also what's something called the Bachmann's bundle, which goes through the atria. So the important thing to remember is that depolarization in a normal heart progresses from the SA node. It travels across the atria, into the AV node, down the AV node, and up the bundles and into the Purkinje fibers, and causing muscle contraction. So I think keeping in mind normal anatomy and how a heart should normally function and how the electrical conducting system should function is extremely important. Obviously, a review of cardiac physiology at the cellular level is also important, because that will further help you understand the medications that we use, antiarrhythmics, and why we use them and where they work. So the respective behavior of different cells in the heart is contingent on their action potentials, and that's a much further, deeper discussion that we won't go into today. So if we think about the heart, we'll just draw it like this. In the middle of the chest, and this is a really bad drawing of someone, and their heart's sitting in the middle of their chest, then the first important thing to do is to understand lead placement. So the most elementary EKGs were first performed, I guess first discovered using Einthoven's triangle, which was just a combination of 3 leads, and the discovery that using 3 points you could then triangulate distances and calculate vectors. But when you're hooking up a patient to an EKG, it's kind of important to understand where your leads are going. So when you look at your EKG printout, you'll have your limb leads, which are leads 1, 2, 3, and you'll also have AVL, AVR, and AVF. So the classic way to remember, and all the leads are color coded when you're in the hospital. So it'll be white on right and smoke over fire. So that means smoke over fire meaning black lead is above the red lead. So you'll have, you know, one lead here, one lead here, one lead down here, and then you'll have a foot lead. You normally put that on the patient's leg, and that composes. So these 4 leads then actually make up these 6 data points. And again, the way that they gather that information from 4 leads has to do with Einthoven's triangle, which requires a much deeper review of both physics and physiology. So that's a simplified version of that. Then you have your precordial leads. So if we imagine that, you know, this is the sternum, then you have V1 that's here, V2, V3, 4, 5, and 6. So it's wrapping around the heart in a fashion like that. Again, it's important to remember that, you know, when you're looking at this, you're looking at it in 2 dimensions, but you have to remember that, you know, you can pretend that the heart is a cylindrical object. And so this is, even though it's in 2 dimensions, you're looking at it in 3 in terms of your EKG. So you can think of your limb leads as giving you an X and a Y representation of what's happening in the heart. And then your precordial leads give you a Z-axis. So you can pretend that you then have another axis that travels this way. So this in effect gives you that representation. Okay, so going back to the same X and Y representation. So the classic teaching is that this is AVL, this is lead 1, this is lead 2, this is lead AVF, lead 3, and AVR. So again, you draw this and you can pretend that the y-axis is kind of in effect the patient's sternum. And so if we do that, then we know that the heart kind of sits in an orientation like this. And if we go back to our normal anatomy and we look at our atria and our ventricles, then we know that the heart is depolarizing somewhere in the direction towards lead 2. It's important again to remember that when cells are depolarizing, you have charge that's emitted from them that's actually going in all directions, but what we're reading on EKG is the mean of the vectors. So if we think about undergraduate physics, we would have a question that would say you have some, you know, object here and 2 trucks want to tow this object, and one truck is towing it this way with this many newtons of force, and the other truck is towing it this way but only with this many newtons of force. Then what's the mean vector? And it's somewhere there in the middle. So when you're thinking about the heart depolarizing, you have to think of the same concept, that, you know, the heart is depolarizing the left ventricle, but the right ventricle is also depolarized, and then the posterior part of the heart is also depolarized. So you have all these different vectors that are happening, and these limb leads are actually only seeing it in the XY axis. Your precordial leads will be the ones that read it in the Z axis. So it would make sense then that most common teaching is that, you know, so when you first look at an EKG, and everyone has their different techniques of reading EKGs, but a lot of people will say rate. Okay, so rate is the first step, and we'll be able to go over that. Rhythm is another step, and that's another thing we can go over, but axis is a big thing and probably something that people don't really understand all that well. And they say, you know, based on diagnostic criteria. They say anything that falls outside of AVF or lead 1, or some people say AVL, would be considered an axis deviation. So most people don't really understand this. They kind of use the method of looking at the EKG itself and say, well, 1's positive and AVF is positive, then it's normal axis. Well, what does that actually mean? So the way that I like to think about it is, if each of these leads that we've drawn on this paper are kind of like a camera almost, and this heart is sitting in the middle. So I have all these photographers looking at this heart that's sitting in the middle of the room. They're all looking at the same object, but they all have a different perspective on it. So then you add one more dimension to that, is the fact that pretend that all these photographers are looking at this heart, but this heart is also in motion. Obviously in the chest it's fixed, but think of it as a race car, and photographer number 2, that race car is driving straight at him. Photographer number 1, it's kind of is in direction, but not entirely. So you can think about it that way. So it would then make sense that when you see an EKG and you see your P, QRS, and then why do you see those? Why is there a positive R wave? Why are there deep S waves? What does all of that mean? So the more directly the vector is traveling towards you, then the more positive deflection you'll have. So for example, if we were to say we're looking at lead 2, then again, so it's important, while the heart cells are depolarizing, you have a bunch of positive ions that are flowing out of the cell. So you can think about it as a wave of positive charges that are flowing towards a cathode, which is your lead. So you have a cathode, so positive towards a positive, and if you think about elementary school or physics or whenever you did this, where you take 2 positive ends of a magnet and you try to push them together, then they deflect one another. Then you have kind of the similar effect that it goes towards a positive lead, and a positive lead causes a positive deflection. So if in an old school EKG, in the original ones where it was like a needle with ink on a piece of paper, then the positive charge flowing towards a positively charged needle would cause a positive deflection on a piece of paper. So you can think about it that way. So if the flow of or the wave of depolarization is traveling directly at some given lead, we can arbitrarily say lead 2, then your R wave is going to be almost entirely positive, because it's actually not seeing anything else. It's only seeing it coming right towards it. But if you were to go to, for instance, lead 1, you probably would still have a positive R wave, but you might start getting some negative waves as well, because part of that vector is also traveling away from it. So the further away that you move from this lead, which is the actual axis, let's say, then the more S component, the more negative component you'll start getting. I think the easiest way to think about this is when you're looking at your EKG and you want to look for, what I like to do is look for an isoelectric lead. So what does that mean? So an isoelectric lead, if we're looking at our EKG, this again, our normal morphology of a QRS. And we can call this line the baseline. Well, then what does the baseline actually represent? The baseline represents the resting membrane potential. That's important to remember moving, for later on when we talk about ST elevations and whatnot. But you treat this line as your baseline. So an isoelectric lead would mean that your R wave, this positive deflection, is of the same amplitude as your S wave. So this distance here is equal to this distance here. Okay, so A is equal to B. So the way that this actually makes sense is going back to our graph. And I like to simplify it and just say if we look at, let's say, lead 1, and even though this isn't a lead per se, this would be, if this is 0 degrees, this would be 180 degrees. So anything that lead 1 is seeing, traveling towards it, the person standing over here would see the exact opposite of that. So if I have a wave of depolarization traveling directly at me, positive ions flowing out towards a cathode would be purely positive deflection. And because the person standing over here, or the electrode on this side, sees the exact opposite of that, meaning that the wave of depolarization is traveling 100% away from it, it's going to be a negative deflection. So if I think about it over here, it would look something like this, versus over here, it would look something like this. So it should be the exact reciprocal of it. So how would I get to a point where it's as positive as it is negative? If I know that I go 180 degrees away from my exact vector, it's the opposite of it, then it would make sense that if I bisect that, meaning that I go 90 degrees to lead AVF, I would then have as much of a positive component as I would a negative component. So knowing that, you can say, okay, if I can find my isoelectric lead, I know that I can find my axis, my vector, by going 90 degrees away from it. So for instance, I'm looking at an EKG and I see that AVF has an isoelectric lead like this, and I go 90 degrees away from it, then I know that my axis is normal, right? Because I'm still between AVL and AVF, and it would be exactly 1. It's really less important to know exactly where it is. If the height of this R wave is 7 boxes and this one is 6 boxes, it's still close enough to give you an approximation. And so you can say, well, how do I know that I need to go 90 degrees in this direction versus 90 degrees in that direction? Well, the way you can think about it is going back to normal anatomy and knowing the heart and knowing where depolarization is. We know that it should normally depolarize somewhere along this line. Different pathologies can change this, such as left ventricular hypertrophy, and it makes sense because if you have a larger heart muscle, especially on the left side, due to long-standing hypertension or other issues, it's going to cause a massive heart muscle, a massive LV, and it's going to generate more voltage. So again, because this is a mean of the vectors, increased voltage coming from the LV is going to pull my axis more towards that side. Conversely, you can think of if you have a massive left-sided MI, so now you have a bunch of infarcted tissue, and infarcted tissue doesn't generate any voltage, then I'm not going to have voltage generated from here, which then pulls the vectors towards that way. So there's going to be this kind of unopposed voltage coming from the right side of the heart that's going to shift my axis more towards the right, or what we call a right axis deviation or right axis shift. So once you have that principle down, you can kind of deduce from other pathologies what you would see. So someone who has long-standing mitral regurgitation, who now has a dilated left atrium, you would anticipate that, again, a bigger left atrium will generate more voltage and therefore pull the axis that way. And you say, okay, well, where would I see that most prominently? Well, since we know that P waves represent atrial depolarization, then it would make sense that the leads that are looking at the left atrium would seem to have a higher amplitude. And that's the basics of axis.